Hi, and welcome back to Ready, Set, GYO, your on-the-go guide to learning gynecologic oncology. I'm Sydney.
And I'm Maya. This is a podcast for fellows by fellows. We are here to help you explore the diagnosis and treatment of gynecologic cancers, master the standards of care, and stay on top of new practice-changing publications.
Let's get ready to GYO!
This is the third episode in a 4-part series on uterine cancer. Today, we're going to be discussing treatment options for advanced stage and recurrent disease. Sydney, what are our learning objectives for today?
Our learning objectives are to describe the upfront treatment of advanced stage endometrial cancer, recognize the landmark trials which help evolve the treatment schema we have today, delineate the treatment options for recurrent disease, and introduce the available biomarker-directed therapies approved for use in endometrial cancer.
Great. We're going to start today's episode discussing upfront treatment of high-risk and advanced stage endometrial cancer. High-risk endometrial cancer encompasses stage 3 disease or higher, regardless of histology or grade, in addition to serous and clear cell histology, regardless of stage, or grade 3 deeply invasive endometrioid carcinoma, as reviewed in a previous episode. Advanced stage disease is stage 3 to 4. These patients have a relatively poor prognosis if treated with surgery alone. Sydney, how do we decide whether we can or when we should proceed with surgery for these patients?
When patients are suspected to have extrauterine disease or to be at risk for extrauterine disease, it's important to get an understanding of the extent or spread, primarily to determine whether their disease is amenable to complete surgical resection. The NCCN recommends considering a CT chest, abdomen, and pelvis for any patient with high-grade disease, for any patient who has had an incidental finding of endometrial cancer after benign hysterectomy, and for any patient with signs or symptoms concerning for metastatic disease. These findings may include a bulky tumor, vaginal or extrauterine involvement on exam, delayed presentation, or abdominal or pulmonary symptoms. In addition, CA-125, molecular subtyping, and ER testing are recommended.
If I have a patient that I do this workup for and find disease outside of the pelvis, what should my surgical intervention be?
Generally, if patients have disease that is limited to the abdomen or pelvis, surgery is recommended with the goal of optimal cytoreduction. Hysterectomy, BSO, and cytoreduction to no visible disease are the standard. For patients with apparent distant metastatic disease, lymph node sampling and removal is not necessary as it would not change the stage or management of the patient. While we do not have randomized trials in endometrial cancer evaluating the effect of optimal cytoreduction on prognosis in surgical debulking procedures, several observational studies and a meta-analysis have demonstrated improved PFS and OS for patients in whom optimal cytoreduction to no residual disease is achieved. Optimal cytoreduction is more likely to be achieved in patients with stage 3 compared to stage 4 disease. Maya, is there anyone in whom primary surgery may not be the best choice?
Patients with visceral metastases, vaginal, bladder, bowel, or rectal, nodal, or perimetral involvement may or may not be surgically resectable. As always, a patient's medical comorbidities and fitness for surgery should also be top of mind when making these decisions. In a future episode, we'll discuss in detail decision-making surrounding feasibility and safety of surgery for patients with medical comorbidities. We will also discuss surgical resection for ovarian cancer, and these principles generally also apply to endometrial cancer. So for the patients who aren't able to get upfront surgery for any of the above reasons, what other treatment options do we have?
For patients that are poor surgical candidates, options from the NCCN include EBRT with or without brachytherapy and with or without systemic therapy, versus systemic therapy alone, and then reevaluation for surgery is appropriate. These are the same options for patients who are not surgical candidates due to unresectable disease. For those with distant metastases, systemic therapy is generally recommended. Reevaluation for surgical resection and/or radiotherapy can be completed based on the patient's response to primary treatment. There are no randomized trials that have evaluated the use of neoadjuvant chemotherapy in endometrial cancer. However, neoadjuvant therapy for stage 4B disease does appear to confer reduced morbidity at the time of surgery. Decision to perform radiation therapy in patients with widespread metastatic disease not amenable to primary surgery should include consideration of the patient's primary symptoms. Specifically, if heavy bleeding and anemia are present, palliative pelvic radiation can be a temporizing measure, and stereotactic body RT, SBRT, can be considered for isolated distant visceral involvement. After surgical intervention for patients with advanced stage disease, Maya, what are our treatment options, and what are the trials that helped form these recommendations?
For patients with advanced stage disease, systemic therapy is the backbone of adjuvant treatment, with addition of chemoradiation or radiation to be considered in specific circumstances. For those with stage 3 or higher disease, systemic therapy is always recommended. This can also be considered an earlier stage high-risk disease endometrial carcinomas in certain scenarios like serous carcinoma, stage 1B, grade 3 disease, or stage 2 disease. Choice of chemotherapy regimen has been evaluated in several trials. GOG 177 compared doxorubicin or adriamycin and cisplatin, AP, to paclitaxel, doxorubicin, and cisplatin, TAP. The TAP regimen improved survival but had increased toxicity. GOG 184 similarly compared the same regimens in patients that had all previously received surgery and radiation. Except for among patients with gross residual disease, the TAP regimen was not associated with improved recurrence-free survival, and again was shown to have increased toxicity. GOG 209, published in 2020, was a non-inferiority trial which randomized patients with stage 3 to 4 disease or recurrent disease to our current standard of care of carbotaxol with TAP, so that Taxol, adriamycin, and cisplatin regimen, which had previously produced the best outcomes for patients with endometrial cancer. If there is a trial from this section to remember, it's GOG 209, which demonstrated non-inferiority of carbotaxol and found much higher toxicity with the TAP regimen. And this trial established carbotaxol as the new standard of care for advanced and recurrent chemo-naive endometrial cancer. Sydney, how does radiation play into this treatment schema?
Great question. And currently there isn't a great, quote, standard recommendation for radiation in advanced endometrial disease. Several trials have investigated whether the addition of radiation to chemotherapy or radiation alone would improve outcomes for patients when compared to systemic therapy alone in advanced stage disease. GOG 122, published in 2006, randomized patients with stage 3 to 4 disease to adjuvant whole abdominal radiation versus cisplatin and doxorubicin. Chemotherapy alone significantly improved both progression-free survival and overall survival when compared to radiation. A possible benefit of chemoradiation when compared to chemotherapy alone had been demonstrated in multiple observational studies, especially for patients with endometrioid histology, high-grade tumors, and positive periaortic nodes, and prospective trials have recently investigated this. In our last episode, we discussed PORTEC-3, published in 2018, which compared adjuvant chemoradiation, cisplatin during radiation, followed by 4 cycles of carbotaxol, versus radiation alone in patients with high-risk endometrial cancer after surgical management. In the original publication of PORTEC-3, there was an 11% improvement in failure-free survival, but no improvement in overall survival in the overall cohort, as well as in the group of patients with stage 3 or serous histology disease. Toxicity and quality of life were worse during the first year after treatment in patients getting combined therapy. A subsequent post-hoc survival analysis of PORTEC-3 with 1 additional year of follow-up, published in 2019, did demonstrate a statistically significant improvement in 5-year overall survival. Overall survival was 81% in the chemoradiation group and 76% in the radiation alone group. When patients were stratified by stage, this overall survival benefit was only seen in patients with stage 3 disease. Those with stage 1 to 2 disease still demonstrated no overall survival benefit from the addition of chemoradiation. Patients with uterine serous cancers also had statistically significant improvement in overall survival with the addition of chemoradiation, with an increase in overall survival by 18.6%. However, the utility of this subgroup analysis is limited by overall low numbers of patients. Previous studies haven't consistently shown differential benefit to chemotherapy in histologic subtypes of endometrial cancer. A subsequent follow-up molecular analysis of PORTEC-3 analyzed results of chemoradiotherapy and the different molecular subtypes of endometrial cancer. This study demonstrated greatest benefit to chemoradiotherapy when compared to radiation alone for patients with p53 mutations, with an improved recurrence-free survival from 36 to 59%. And patients with p53 mutations benefited at all stages of disease. This benefit may have been from the addition of chemotherapy rather than specifically chemoradiation, and there was no chemotherapy alone group in this study to compare against. So, PORTEC-3 told us that chemoradiation may actually improve overall survival in some patients with stage 3 disease, and molecular subtyping could help guide that choice, with benefit from the addition of chemotherapy to radiation compared to radiation alone for p53 patients.
GOG 258 was then published in 2019. This phase 3 randomized controlled trial evaluated adjuvant chemoradiotherapy versus chemotherapy alone for patients with stage 3 to 4A or high risk endometrial cancer. In this study, neither PFS nor OS were improved with combined therapy compared to chemo alone. The patterns of recurrence were different in the different arms, with the chemoradiation arm having less vaginal, pelvic, and para-aortic recurrences, and the chemotherapy arm experiencing less distant recurrences. Therapy completion rate was higher in the chemotherapy alone arm, with 85 versus 75% of patients finishing their regimen. Based on these studies, EBRT currently can be considered for patients at high risk of local regional recurrence, so stages 3B and 3C, understanding that it won't improve time to recurrence or overall survival and will increase toxicities. How else has chemoradiation been evaluated in advanced stage disease?
I'm glad you asked. The Lunchbox trial was published in December of 2023. This was a phase 3 randomized controlled trial evaluating chemoradiation designed to investigate the impact of sequencing of radiation and chemotherapy in advanced endometrial cancer. They enrolled patients with FIGO 2009 stage 3 to 4A or stage greater than or equal to 1C serous or clear cell endometrial carcinoma. Patients were randomized to either chemoradiation with cisplatin, followed by 4 cycles of standard dosing carboplatin and paclitaxel, which they modeled after the experimental arm in GOG 258, or carboplatin and paclitaxel with 3 cycles, followed by EBRT, followed by an additional 3 cycles of carboplatin and paclitaxel, a sandwich model, hence the name Lunchbox. At their first interim analysis, there were no differences in progression-free survival or overall survival, and the trial was closed early due to a pre-planned futility analysis. In addition to chemo and radiation, I've heard that there have recently been big advances in therapeutic options for endometrial cancer, specifically in regard to immunotherapy. Maya, what do you know about that?
Based on the results of the RUBY and NRG GYO18 trials, pembrolizumab and dostarlimab are now considered Category 1 for adjuvant treatment of advanced endometrial cancer for patients meeting certain criteria of disease based on trial inclusion. These are both checkpoint inhibitors which target PD-1. NRG GYO18, published in the New England Journal of Medicine in 2023, was a phase 3 randomized controlled trial which enrolled patients with stage 3 or 4A with measurable disease, stage 4B with or without measurable disease, and any recurrent endometrial cancers. Patients were randomized to carbotaxol plus minus pembrolizumab. They were stratified by MMR status, with roughly 2/3 of patients having MMR proficient disease. 95% of patients had not received prior chemotherapy, and 63% had not received prior radiotherapy, and most had had surgical intervention, almost 90%. Patients with prior therapy were admitted if their treatment-free interval was greater than or equal to 12 months. Notably, all histologic subtypes, with the exception of carcinosarcoma, were included in this trial. The primary outcome was progression-free survival. With 12 months of follow-up in the MMR deficient cohort, the progression-free survival was 74 versus 38% favoring pembrolizumab, with a 70% lower risk of disease progression or death. In the MMR proficient cohort, median PFS was 13 versus 8.7 months, with a 46% lower risk of disease progression or death. Rates of greater than or equal to grade 3 adverse events were higher in the pembrolizumab groups. The RUBY trial, also published in the New England Journal in 2023, was a phase 3 clinical trial which enrolled patients with endometrial cancer not amenable to curative therapy. This included patients with stage 3A to 3C measurable disease, stage 3C1 with high-risk histologies regardless of measurable disease, and stage 3C2 to stage 4 disease regardless of measurable disease, as well as recurrent endometrial cancers. Patients were also stratified by MMR status. This trial did include patients with carcinosarcoma. Patients were randomized to carbotaxol plus minus dostarlimab. Primary endpoints were progression-free survival, and they had about 24 months of follow-up at the time of publication, as well as overall survival. The PFS at 24 months in the overall population was 36 compared to 18% favoring dostarlimab. In the MMR deficient population, PFS was 61 versus 16% favoring dostarlimab, and the overall survival was 83 versus 58%. In the MMR proficient population, PFS was 28.4 versus 19% favoring dostarlimab. The overall survival in the pMMR population trended towards improvement, but the confidence interval crossed 1. Grade 3 adverse events were more common in the dostarlimab group. It's important to note that for both of these trials, patients with stage 3 disease with no measurable disease or completely resected sentinel lymph node positive without enlarged nodes were not included. As such, extrapolation of findings needs to be carefully considered. It's unclear at this time which form of adjuvant treatment is best in this population, especially in patients with pMMR tumors. Sydney, has there been anything else published recently that has improved outcomes for patients with pMMR tumors?
As we just discussed, the RUBY and GY018 trials demonstrated efficacy of checkpoint inhibitors in immunotherapy in all comers, including in pMMR subgroups, but had improved response in patients with MMR deficient tumors. As pMMR endometrial cancers make up about 75% of all endometrial cancers, treatment options for this subgroup are sorely needed. The DuoE trial was a phase 3 randomized controlled trial also published in 2023, which randomized patients to carboplatin and paclitaxel plus minus durvalumab, a PD-L1 inhibitor, and a third arm with carbotaxel durvalumab plus olaparib, a PARP inhibitor. This trial evaluated the hypothesis that adding PARP inhibitor, which addresses homologous recombination deficiency, to checkpoint inhibitors, which address MMR and MSI status, may improve outcomes. It's important to note that there was not an arm in this trial that had PARP inhibitor alone. As such, many have concerns over the applicability of the results, as we can't compare either therapy to PARP inhibitor alone. Patients had stage 3 to 4 endometrial cancer or recurrent endometrial cancer with greater than or equal to 12 months since last treatment and were stratified by MMR status. Primary outcome was progression-free survival. Both durvalumab and durvalumab plus olaparib demonstrated improved PFS at 18 months compared to chemotherapy alone. In the intention to treat population, both the addition of durvalumab alone and durvalumab plus olaparib improved PFS, 10.2 months and 15 months respectively versus 9.6 months in the chemotherapy group. In pre-planned subgroup analyses, patients with MMR proficient tumors conferred significant additional benefit with the addition of olaparib to the durvalumab carboplatin paclitaxel triplet, increasing progression-free survival from 10 months to 15 months. Notably, progression-free survival with carbotaxol alone was 9.7 months. Patients with MMR deficient tumors benefited from the addition of durvalumab to control, with a progression-free survival not reached compared to 7 months in control, but did not further benefit from the addition of olaparib. In patients stratified by PD-L1 status, triplet therapy had the longest progression-free survival of 20 months, compared to durvalumab with 11.3 months and chemo alone with 9.5 months. Adverse events and treatment discontinuation were highest in the triplet therapy group. Maya, do you know of any other targets we can take advantage of?
There are also ongoing trials evaluating the use of atezolizumab in combination lenvatinib and pembrolizumab in the upfront setting. In a paper published by Fader et al. In 2018, for advanced stage serous endometrial cancers with greater than or equal to 2+ HER2 expression on IHC, the addition of trastuzumab to carbotaxol significantly improved both PFS from 9 months to 18 months and overall survival from 24 months versus not reached in the trastuzumab group in the upfront setting. In the recurrent setting, this regimen improved PFS but did not significantly improve overall survival, which we'll discuss later. As a result of this trial, trastuzumab is recommended by the NCCN in combination with carbotaxol as first-line therapy for advanced stage HER2-positive uterine serous carcinoma. It's also recommended for HER2-positive carcinosarcoma, which we'll discuss in our next episode. Additionally, oral selinexor can be considered as maintenance therapy after first-line chemotherapy for advanced or recurrent endometrial cancer, as published in the Phase 3 SIENDO trial in December of 2023. Selinexor inhibits exportin 1, resulting in nuclear accumulation of tumor suppressor proteins, including p53. The primary endpoint of progression-free survival was only met in the audited analysis with a hazard ratio of 0.71. PFS did not meet statistical significance in the intention to treat group in the initial study analysis, as incorrect chemotherapy response stratification data for about 3% of patients were identified. Importantly, patients with TP53 wild-type endometrial cancer had a median PFS of 13.7 months with selinexor versus 3.7 months in placebo. That was a lot of material to cover, Sydney. So once we've treated our patients, and if we're able to get our patients into remission, what do we do then?
After primary treatment, if patients have responded and are without evidence of disease, they enter surveillance. This consists of a physical exam every 3 to 6 months for 2 to 3 years and then spaced out, and serial CA-125 if it was previously a tumor marker for them. During this time, patients should get education on signs and symptoms of recurrence, and exam and imaging can be performed at any time if there is concern for recurrence. If our patients recur, or if they progress after primary treatment, what options do we have then?
In the world of advanced endometrial cancer that progress on primary treatment or recur, there are so many options for treatment. The options depend on what the primary disease type was, where the recurrence is, and how long the disease took to recur. The NCCN guidelines are a great place to look this information up because it's a lot to remember. Generally, radiotherapy, surgery, and systemic therapies are all options. Let's talk a little bit about local regional recurrences.
For patients that have recurrences confined to the vagina or pelvis, options include EBRT plus minus brachytherapy if patients haven't received prior radiation, plus minus systemic therapy. If patients got primary radiation at the site of recurrence, surgical exploration or systemic therapy can be considered, as well as brachytherapy. You can also think about palliative EBRT to address symptoms. GOG 238 is not yet published and is evaluating concurrent chemotherapy and XRT in the treatment of pelvic confined recurrent endometrial cancer. Maya, what if patients have disease that recurs distally?
Distally recurrent disease or widely metastatic recurrences need to be assessed for extent and location of disease. If the recurrence is isolated, you can consider surgical resection or targeted radiation. If disease doesn't respond or isn't amenable to local treatment, we need to consider systemic therapy. Similarly, patients that present with widespread recurrences are generally treated with systemic therapy with consideration for targeted SBRT on a case-by-case basis. How do we choose which systemic therapy to use for recurrent disease?
This decision is highly dependent on the molecular characteristics of the tumor. First-line therapy for recurrent disease includes repeat platinum-based regimens with or without the addition of directed therapy. Both the RUBY and NRG-GY0118 trials, as well as the FADER paper evaluating trastuzumab for serous cancers, included recurrent disease in their studies. As such, patients with the first recurrence may be eligible for the addition of pembrolizumab, dostarlimab, or trastuzumab to standard carbotaxol. Patients with MMR-proficient tumors may be candidates for lenvatinib plus pembrolizumab. The Keynote 775 trial was published in 2022 and evaluated the use of len-pem for patients that had previously received 1 to 2 prior lines of platinum therapy. This study demonstrated an improved progression-free survival of 7.2 versus 3.8 months and overall survival of 18 versus 11 months in patients treated with len-pem compared to investigator's choice chemotherapy. Statistical analysis was planned for the MMR proficient and overall population, and exploratory analysis was presented for the MMR deficient population. In the MMR proficient population, PFS was 6.6 months versus 3.8 months, and overall survival was 17 versus 12 months. Almost 90% of patients on len-pem experienced greater than or equal to grade 3 adverse events, and 67% required a dose reduction. What about patients with MMR deficiency?
Patients with dMMR, MSI high tumors may be candidates for checkpoint inhibitors as monotherapy. The use of pembrolizumab is based on results from the Keynote 158 trial. This was a basket trial, i.e., disease site agnostic, which included 79 patients with MSI high or dMMR endometrial cancer. These patients had an overall response rate of 48%, a median PFS of 13 months, and the median overall survival was not reached at time of publication. Avelumab, an anti-PD-L1 therapy, was evaluated in a phase 2 trial. Patients with dMMR had an overall response rate of 27%, regardless of PD-L1 status. Dostarlimab and nivolumab have also shown clinical activity as solo therapy in patients with dMMR endometrial cancer. If patients have an NTRK fusion mutation, single-agent larotrectinib or entrectinib are targeted therapies available as subsequent therapy. Finally, the use of olaparib plus minus cediranib, which is a VEGF tyrosine kinase inhibitor, were evaluated in the NRG-GY012 trial for recurrent endometrial cancer. This was a negative study that did not meet their primary endpoint of improved PFS, and olaparib alone showed no significant benefit. What about hormonally active tumors?
Patients with ER/PR-positive tumors are also candidates for hormonal therapy. No particular drug or dose or schedule has been found to be superior. GOG 122 and 153 demonstrated that tumors that are low grade, well differentiated, and have had a long disease-free interval are most likely to respond. Low-dose therapies may be equivalent or better than high-dose hormones. Fiorica et al. Published a phase 2 trial in 2004 evaluating alternating megase and tamoxifen in patients without prior hormone or cytotoxic therapy. The regimen was active and in some patients produced a prolonged response. These therapies haven't been compared directly to cytotoxic agents. If patients have disease progression on hormonal agents, a switch to cytotoxic therapy should be considered.
HER2-targeted therapy is also an option for patients with recurrent endometrial cancer that are HER2 positive. Based on the results of the 2018 FADER paper, which showed an improved progression-free survival from 7 to 9.2 months in recurrent uterine serous carcinomas that overexpressed HER2, trastuzumab in addition to carbotaxol is a preferred first-line option for recurrent serous endometrial carcinoma, as well as carcinosarcoma that is HER2 positive. Trastuzumab deruxtecan, which is an antibody-drug conjugate, is another option for patients with HER2 overexpressing endometrial carcinoma regardless of histology, as long as their IHC staining for HER2 is greater than or equal to 2+. The DESTINY trial was an open-label phase 2 study evaluating trastuzumab deruxtecan in patients with HER2-expressing progressive or recurrent solid tumors. Out of 267 total patients, 40 had endometrial cancer, with 60% of those patients having 2+ HER2 IHC and 40% had 3+ expression. The overall response rate among patients with endometrial cancer was 57.5%, the highest of any disease site, with an 84% response rate among patients with 3+ HER2 expression and a 47% response rate in those with 2+ HER2 expression. Of note, cervical and ovarian cancers were also included and had response rates of 50 and 45% respectively. Based on the results of this trial, on April 5th of 2024, the FDA granted accelerated approval to trastuzumab deruxtecan for patients with, quote, unresectable or metastatic HER2-positive IHC 3+ solid tumors who have received prior systemic treatment and have no satisfactory alternative.
Several studies have evaluated the use of PI3K and mTOR inhibitors in endometrial cancers. mTOR is in the PI3K pathway, and endometrial cancer has high rates of alterations in this pathway, which work to incur resistance to hormonal therapy, lending biologic plausibility to the use of these drugs in combination. GOG 248 evaluated temsirolimus plus minus megase and tamoxifen in advanced and recurrent disease. The combination arm closed early due to excess DVT risk. In the single-agent arm, temsirolimus had an overall response rate of 22%, similar in patients with or without prior chemo. In 2015, a phase 2 trial was published studying the combination of everolimus, an mTOR inhibitor, and letrozole in patients with recurrent endometrial carcinoma. Among the 38 patients enrolled, a clinical benefit rate of 40% and an objective response rate of 32% was observed. GOG 3007, published in 2022, evaluated everolimus with letrozole versus tamoxifen with medroxyprogesterone acetate. In this study, the overall response rate was 22% in the everolimus letrozole arm versus 25% in the megase tamoxifen arm. Patients who were chemo-naive had a markedly higher response rate, 28 months of progression-free survival versus 4 months, with everolimus letrozole compared with tamoxifen megase, which was an interesting finding that is yet to be evaluated in further studies. The everolimus arm had higher toxicity but had a lower thromboembolic rate. Another phase 2 trial targeting this pathway was published in 2022, evaluating the use of letrozole with abemaciclib, a CDK4/6 inhibitor. CDK4/6 is downstream of PI3K and works to drive cell cycle progression. In this study of 30 patients, there was an objective response rate of 30%, with all responses in endometrioid tumors. Responses were seen regardless of grade, prior hormonal therapy, MMR status, and PR status. P53 mutation was a negative predictor of response to this regimen. Speaking of toxicity, a lot of patients have experienced significant toxicity in their primary treatment. Often these patients are hesitant to restart a regimen that might cause additional toxicity or side effects. What can we do to provide patient-centered care for these people?
If patients cannot tolerate multi-agent chemotherapy for any reason, there are a variety of options for single-agent chemotherapy. Choice should be individualized based on prior side effects and current functional status. Paclitaxel is typically the most active single-agent therapy in the recurrent setting, and liposomal doxorubicin can be a good choice for minimizing toxicity. Bevacizumab has also been studied in advanced and recurrent endometrial cancer. Observational data and phase 2 trials have demonstrated improvement in PFS and OS with the addition of bevacizumab to carbotaxol, and it can also be used as a single agent. Ultimately, when choosing therapies for recurrent disease, the most important piece of the decision-making puzzle is meeting your patients where they are, recognizing their past treatment modalities, assessing and respecting their goals of care, and choosing an option that works for them. If patients decide not to pursue further therapy, our next best option is best supportive care and palliative therapy. We'll discuss principles of palliative care, symptom management, and end-of-life care in a future episode.
That's all we have for you today. We hope you learned something on today's episode of Ready, Set, GYO, a podcast for Gyn-Onc Fellows. Here are your key takeaways from today's episode. If there are signs of extrauterine disease, surgical cytoreduction is the standard of care if feasible for patients with advanced stage disease. based on observational and retrospective data demonstrating improvements in overall survival with optimally cytoreduced disease.
For advanced stage disease after surgical intervention, or in patients in whom surgery is not feasible, systemic therapy is considered the foundation of adjuvant therapy. Addition of immunotherapy in the form of pembrolizumab, dostarlimab, and/or trastuzumab is a recent practice change. Depending on risk of recurrence, radiotherapy can also be considered.
There have been many trials to determine the optimal form of adjuvant treatment. Each GOG trial was foundational to determine the next step of inquiry and ultimately helped us arrive at the systemic treatment recommended today: carboplatin plus paclitaxel plus minus targeted therapy.
The location of recurrence and prior therapies a patient has received contributes significantly to choice of recurrence therapy. Generally, radiotherapy, surgery, and systemic therapy are all options. Radiotherapy and surgery are most often used in local regional recurrence. Systemic therapy, including choice of cytotoxic chemotherapy, hormonal therapy, and/or biomarker-directed therapy, is more often used for unresectable metastatic disease.
Biomarker-directed therapies represent a changing landscape in treatment of endometrial cancer, both in the upfront and recurrent settings. Knowledge of their indications, dosing, and risk factors are important, and these details will be further explored in a future episode.
This has been another episode of Ready, Set, GYO, your source for all things gyno.
If you'd like to check out today's show notes, take some practice questions, or explore resources we use to create the podcast, head to readysetgyo.com, the companion website for our podcast. We encourage you to reach out if you have ideas for new episodes, questions or comments about existing episodes, or thoughts of how we can make this podcast even better suited for you. We're excited to continue to learn with you.
To stay up to date on all things Ready, Set, GYO, check out our Instagram and Twitter at ReadySetGYO.
To support us and our production of future episodes, check out our Patreon at ReadySetGYO.
This episode was recorded by Sydney Oesch and Maya Gross.
Our sound editor is Brogan Brown.
Our media and website manager is Sky Jacobson.
We'd like to thank Dr. Taylor Oriana, faculty at the Medical University of South Carolina, who reviewed the content of this episode today for accuracy and completeness.
Sydney and Maya signing off.